Well, without further ado, let's get started. I know we're very excited about this panel. Community-led monitoring is really a very, very interesting topic, and we have excellent panelists to share their experiences, their lessons learned with us today. I've been looking forward to this session all week, and as good events usually go, we always save the best for last. So this is really going to be an honor. So I just want to say again, good morning, good afternoon, good evening to everyone who's here to join us. Welcome to today's session, Community-Led Monitoring, Learning from Communities to Improve Service. And that's something we're all looking to do. And as I mentioned, we are really privileged to have three distinguished speakers hailing from Mozambique, India, and Malawi today, who will share their experiences with us. Also some practical tools and some lessons learned, as well as some unexpected results and impacts of their CLM activities. Just to note, we do also, I want to thank Sina Wolden Tensai, who will be our note taker today, as well as Latham Avery, who is helping us with the projection here of our slides. And before we begin, I did want to invite you to use the Q&A function. You will see at the bottom of your screen, there is a button that says Q&A. Enter your questions there to the panelists. You can do so at any point during today's session. And it's easier for us to keep track of your questions if you enter them in that space. You can also use the chat, but sometimes those start rolling up and we may lose sight of them. Do, if you can, use that Q&A function. Also, if you require it, there is translation services. You'll also see on the bottom of your screen the French and Portuguese options. So do use that if it will help you follow along the conversation a bit better. Without further ado, I'd like to ask our panelists to introduce themselves as they share their presentations with you or their comments. And we're going to start now with Grace Kumwenda from Pakachiri. Grace?
Thank you so much, Mike, and it's really an honor to be part of this panelist. My name is Grace Kumwenda. I'm a chief of party for a program called Local Endeavors for HIV Prevention and Treatment in Malawi. In short, it's called LPM. We are implementing among female sex workers, adolescent girls and young women and their sexual partners. We are delivering services using drop-in centers, outreach clinics, but also public health facilities. Next. So I'm mostly going to just talk about what community-led monitoring means to us as an organization. And I'll briefly show you a model that we're working with and a little bit of the practical tools that we've used over time. Next. So for us, in terms of community-led monitoring, it's basically having the members of the community, female sex workers, at the center of the work that we do. We've laid that over time. It has helped us quite a lot to actually understand their needs in terms of service needs, but also understand program gaps that we have. In terms of the model that we're implementing in Malawi, we do have several data streams. So first of all, we have the data collection part. And for the data collection part, there are several data streams that come in. The first one is by annual client satisfaction surveys. This is done twice every year. It's a quantitative process, and I will share a little bit more about it in the next slide. Apart from that, we also do have routine quality assessment processes that we do conduct, and we use DIC committees, and drop-in center committees basically are led by female sex workers. So the process that happens there really is led by the community itself. We also conduct formative assessments at the end of every year, and we use focus group discussions to just engage female sex workers. We have routine client feedback that comes in at drop-in center level using suggestion boxes. We do have peer card feedback that comes in through our peer educators and peer navigators literally almost every week as we engage with them. But recently as well, we've introduced site assessments. And for the site assessments, what has been critical, I know it's for external partners, they'll come in, assess how you're doing, sometimes even internally reflect. But what has been critical at the moment is having members of the community being part of that site assessment and helping us understand areas that need improvement. So all these data streams come together and we collect the data and analyze it. And this data is then fed back into the healthcare providers at facility level, at DIC level. I have to say that in terms of the model, the way it works, it doesn't stop at drop-in centers. It goes beyond that to also go into public health facilities because we want to also assess experiences of stigma for key population. Next slide. I did talk about biannual client satisfaction survey. What you're looking at is an example of the form that we use. As I said, it's a quantitative process that we do, and the tool is administered by outreach workers who are also sex workers. In FY21, we actually innovated and we brought in female sex workers who are outside the program. This helped us to be a little bit more objective than ever before. So we interview female sex workers to understand their experience with service delivery and with healthcare workers. It is anonymous, so there's no need to collect personal information. And we also assess if a site is KP friendly. We also assess any experience whatsoever that a member of female sex worker or a member of key population may experience in terms of stigma. And it also provides us an opportunity just here in terms of how they want to see services improved over time. Next. So the data I'm showing you now is really coming from our DIC data stream. And we did collect interviews from female sex workers from 12 drop-in centers. And the findings for the FY21 data basically told us that over 90% were satisfied with the services they were receiving. But with community-led monitoring, that's not really the focus. The focus is where the gaps are. So we did take a lot of time to understand what made those few people who are not satisfied with our services, what made them say that they are not satisfied. So they did mention a few factors, and those included, some of them indicated that the drug that they received was not appropriate. Others said they needed an emergency ART supply, but they did not access it at that particular time. Others mentioned that there were no STI drugs, and others mentioned condom stock outs. I think for us, understanding these factors is more critical because we do realize that if we don't address the gaps, the problem at the end is people who are dissatisfied with the services will increase. So we want to make sure that those gaps are being addressed. Next slide. This is just talking to a few satisfaction parameters in terms of how the things that mattered to female sex workers. So for them, the biggest one was confidentiality of health information. They needed privacy. They also talked about availability of the services that they needed at the facility and staff friendliness and professionalism. If you look at that, there are other factors that matter, but these were quite important. And I have to say that this was applicable for those, the drop-in centers, but also the public health facilities. Next. So just to briefly share in terms of some of the impact that we've seen in terms of CLM on the quality of services. We've seen a lot of improvement in the way that female sex workers are walking into drop-in centers, and that is also affecting us in terms of HIV testing services uptake and all the other indicators. And that has really come in because we've been responsive to the needs that they've mentioned within the service. A simple example that I can talk about is we've changed geographical locations twice, where female sex workers say we don't feel safe in space, it's not private enough. We've actually had to move the drop-in center and to move into another space. We've also expanded package of services because of the feedback that they've provided us. There was a time that they actually said, we are able to access HIV testing, ART, what about cervical cancer screening? So we added that to the service package at drop-in centers. At the same time, we've started extending hours of operation, but also operating on Saturdays and Friday nights. This has really been out of the feedback that has been coming in through CLM. But overall, I think broadly speaking, this has been a great tool for us in terms of just understanding where we need to put our attention to in terms of healthcare orientation on key population services. But broadly at country level, it has also defined our agenda as an organization, advocacy agenda, in terms of what matters for key population. When we sit in those spaces and advocating for key population services, what should we look out for? I think I'll leave it there. Thank you so much.
Thank you so much, Grace. I can imagine there's already a lot of questions. There's so much to capture there and the impact that the CLM activity has had. Thank you so much. We will discuss further for certainly in just a moment. We're going to move over to Adolfo. Thank you, Adolfo.
Thank you, Michael. Good afternoon to everyone. Good morning for those who are still morning in the country. My name is Adolfo Kambul. I'm from Mozambique, and I'm the chief of part of NET program in Mozambique. So we are implementing a community HIV program, which is aimed to improve the retention outcomes among our patients, with focus to reach the OHA goal, which is 95, to manage to test and to find at least 95% people who have HIV, and also link them to care and treatment, and also support them in order to sustain or viral suppression. So throughout our program implementation, this is the second year. We are on the third year of implementation. We have faced so many difficulties in order to improve retention among our patients. And doing an analysis of what's going on, we found that there are a lot of challenges that cause or are reflected as a barrier for our patients and community to improve their retention on treatment, such as illicit charge on health facility siting. People report that. Also, they report they have to wait a long time at their facility, and they have to walk long distance, and when they reach their facility, they have to wait for long times at that facility. Also, that this is one of the downsides, one of the major implications for drop off of treatment, and also there are some drop out of medication at that facility, and also little or very poor knowledge on terms of rights of the patient among the health staff. So with that on mind, NET as an organization has large experience in implementing such community-led monitoring in Mozambique since 2011, have been implementing such monitoring process, and we saw this opportunity to implement on the context of HIV in order to improve the retention and adherence of our patients, so that we may expect good outcomes in terms of viral suppression. So in our context, so Michael, yeah. Can you go back to the first slide? Okay, thank you. No, second one. Okay, thank you. So in our context, specific context, the CLM is aiming to improve the quality of HIV service delivery by engaging people living with HIV and their community in monitoring the quality of INT service provided in the target health facility. So the aim is to provide voice to the patients, to make sure that the patients, they have moment and they can express how they see the service and what are their proposals in terms of improve the service. Once they see the change and they feel that they are part of the change, surely the patient will also adhere, or will start also to make part of the program, and we hope to see improvement in their retention. Please, next slide. So this is the community-led monitoring cycle. We start with community mobilization, where we mobilize community. It's very important to engage communities, stakeholders at community, the local leaders, and the beneficiaries to explain what is community-led monitoring, what does it stand for, how we expect, what we expect to reach with these activities, and what are their main roles. It's very important. So on this, we select the target group. Most of them are people live with HIV. We separate in 5 different groups. One group are health facility staff on that specific area. Another group are pregnant women and breastfeeding women, HIV positive, all of them. And also we have youth groups, we have male groups and female groups, all of them with patients living with HIV. And then we train them, and together each group score each service. I mean, there are several indicators directly related to the retention outcomes in that specific health facility. So that group start to score each kind of service. For example, how do you feel is that the waiting time at the facility, is it good for you? Is it bad? So these groups start to scoring. And after that, because there are many groups who do that, so there is an opportunity to do the systematization of all of those findings for each group. And after that, each member for each group, they come together in one, in order, because they are, each group have to come up with 5 top priorities according to them. But we have many groups, and at the end of the day, we need to have only 5 priorities. So each member of each group, they come together in a moment where they do the legitimization of the single community matrix, where they find out what are the top 1 among all the groups, what are the top 5 factors, top 5 indicators that need to be improved. So with that said, the next stage is the interface preparation, where the project staff prepare the community to meet with health facility staff and discuss all those top 5 challenges according to the understanding of the community and the members of that community, and also of the patients for that health facility. And then we have the interface meeting, where we have the health facility provider, those who are on front line on providing HIV care service to the patient. And then we have member or representative from the community and for each group. So they come out, they discuss that those 5 priorities. The health facility, they give their inputs, they give their feedback. Also the clinical providers who are invited are part of the process. So with that said, at the end of this interface meeting, they come up with strategic plans, action plan of how they're going to improve those worst 5 indicators for that specific health facility. As they agree on that, this process start to be, we hope that the community take ownership of that, and also they are eager to follow up and to do the monitoring process of that situation, how things are moving forward. So this is the institutionalization and the evolution of the process. Of course, some of the solution may need different level of actions. For example, some of the solution is to take action facility setting, but it's at provincial level, even national level. So depending on this, we can scale up to present this issue and also to advocate in order to get the needed support in order to improve this problem, to bring out solution for the problem. Next slide. So what our strategy to engage the main stakeholders? We have different stakeholders. We have the government, community, health staff, and also clinical partner. For the government, one of the important things we do is before we start to implement these activities, it's important to go to the local leaders at district level, at province level, even national level to present this strategy and to reply all the questions that they have, the aim for that, what we expect to reach after this program, because the retention, it's a national problem. It's perceived by Ministry of Health as a national problem, also by the clinical partner, even the health facility staff. We didn't face much barrier in order to improve this. And also our National Ministry of Health, they have a quality improvement program. So because of that, we have advocated to have this community lead monitoring process as part of the ongoing quality improvement process for the Ministry of Health. We managed to achieve this. I think furthermore, I can bring some evidence of this in terms of has experienced what we have achieved so far. So for community also, it's very important to engage the stakeholders at community level, the local leaders, the religious leaders, those who are in power of communities also to engage them, to explain what is community-led monitoring, what does that aim for, and what we expect to achieve. And once they see the value of these activities, surely they will give themselves in order to make sure that this program succeed, and in order this program succeed. Also for the health staff, we also engage them in terms of explain what the process is. We make sure that in the beginning we feel that the staff were a little bit afraid because they saw this as a platform to show their lack of the problem the health facility have, and they thought that because of that they will be blamed for that and this kind of thing. But we engage them. We have advocated to show that this is not to point out the problem just that, but it's to seek solution together, community and health facility staff to seek solution, to find solution, and also we can have improvement on our program and have the patient also satisfied for that. Next slide. So as some of the lesson learned for this specific contest, we have seen great involvement from the Ministry of Health and Health Facility, which has allowed greater ownership of the activities. We have now, because of this program, Ministry of Health has also requested and rated to develop some strategy, for example, a specific strategy in order to avoid and to prevent the illicitly charged health facility. The Ministry of Health have requested rated to come out to develop this strategy. So this is part of the ownership process we were eager and we were looking for to have, and we can see this happen. And also we have seen good collaboration with clinical partners. Clinical partners need to, it's also important for clinical partners to have the patient on IRT treatment, to be retained on treatment, and then to have good adherence on treatment for the sake of viral load suppression. So because of that, they see the importance of this process. So we have good collaboration with clinical partners, but also with that, clinical partners is very important because they are part of the solution of the problem. When we come up with action plan, so clinical partner has the partner who support the health facility. So they are very important on this role. So it's very important. And also CLM tool is it's very important in terms to improve interaction between community and health facilities. Again, community start to see that they have an active role on their health, on their specific health. So they feel that their voice are heard. So this is very important because communities start to see that they are part of solution of those problems. So it's very important. We have some specific challenge for this particular context of implementation. The rainy season, as Michael was saying in the beginning, yes, we have this rainy season and also the sowing season. So it makes it difficult to bring community together in order to conduct this cycle of this program. And also the COVID-19, it has been challenged to operate because there are some restriction in gathering people, and also the distance between health facility and the community. So this is also some of the challenge we have faced.
Thank you.
And finally, yes.
Just in the sake of time, we'll move on to Shama's intervention. Thank you so much, Adolfo. We will come back and discuss some of the points that were raised. You're already getting some really interesting questions in the Q&A box.
Thank you, Mike.
Thank you. Shama?
Thank you very much, Mike. Namaste, everyone. My name is Shama Karkar, and I'm privileged to be representing Swasti and the community-led monitoring work that we started in India just about a year ago. I think Mike wanted us to talk about a little bit about ourselves. So my training is in social action and community organizing, and I've spent about 20 years in public health, and about 10 of those years working very closely with community organizations here in India, South Asia, and looking at solving some of their most pressing challenges. As an organization, we're 19 years old, and we were actually born during the time that the HIV response in India was undergoing a sort of a paradigm shift. And I think we've had a strong conviction that communities affected by HIV are central to the HIV response. And we have this 19-year history of working with key population groups here in the country. And I think because we've been working on community systems, strengthening community-led structures and mechanisms, how communities, through individuals, community organization groups and networks interact, coordinate, and deliver their responses is how we came to be the first in the country to actually be initiating the community-led monitoring work here. For us, community-led monitoring is a mechanism and as part of the larger community system strengthening effort, which is currently underway here in India, led by the National AIDS Control Organization, which is part of the Ministry of Health. And for us, what we've been working on is how do we get community representatives to actually get involved in a multi-stage process of identifying the key enablers as well as the barriers, and work with stakeholders, including the community, to try and solve for those problems. I think I saw a lot of similarity with the work that Adolfo and Grace are doing. And I think it's going to be a learning experience for us as well as we move further on with the work that we're doing here in the country. So what we've done in the last year is we've worked in 7 districts of 2 states in India, where we identified, Adolfo called it mobilizing, and identified and oriented about 271 community champions. So these were across all key population groups. We were working with women in sex work, men who have sex with men, trans people, people living with HIV, as well as people who inject drugs. We trained about 225 of them, and eventually about 164 of them worked with us in going into about 439 different facilities, again, across the variety of different HIV service providers in these districts. So from integrated counseling and testing facilities to ART providers, TB providers, STI care providers, as well as targeted interventions, which is the DIC and the outreach services. And we collected information or feedback from 4,519 individuals from the community, as well as staff in all of these facilities. And we did this during a period of about 2 months. We started our work just prior to the second wave and continued post the second wave. And I must acknowledge the support of the community, the various state and national officials who've been from the HIV program who've been involved with us, and of course my own team, because we ensured that we listened to what the community had to say, and we did it while staying safe. The feedback or the information that we got from both, we actually used structured questionnaires similar to sort of what Grace was showing. We used the questionnaires and we converted them into something simple like a survey tool, which could be put on Android phones. And we trained the community champions to administer the questionnaire in the facilities. So they worked with their own peers to collect their feedback, as well as with the staff in all of these facilities. And we followed this up with group discussions to sort of understand their perspectives on health services, including HIV and COVID, as well as look at social protection and livelihoods. And the analysis of this information, we used just simple Excel and macro and formula to actually generate a community report card, again, something that Adolfo mentioned. And we did this facility-wise to identify very specific rating that the staff was providing to their own facilities and the community was providing to that facility. So we have a comparison of what the staff said and what the community was saying for each facility. We also looked at sort of some common issues at a district level. So while some districts had about 75 facilities that we were looking at, some had more and some had less, right? And within each of these, based on these findings, we have interaction meetings very similar to what I think Grace and Adolfo were talking about. We go back then, starting from the top, starting with the national and then the state levels, back into the districts to look at problem solving. And that's currently where we are in the process of actually problem solving. I'll stop there and hand it back to you, Mike.
Thank you, Shama. Thank you so much. We did just lose you on video. Is it perhaps possible? Also, Adolfo, if your video is working.
I'm so sorry. I didn't realize I was off video.
No problem. Thank you. But thank you all so much. And thank you to Grace and Adolfo. I noticed you've already been responding to some of the questions that have come in through the FAQ. So others, if you would like to add any other questions, please feel free to do so. We just have a couple of questions for our panelists now, and then we're going to open it up to our attendees to also interact and share their questions. So my first question, and I think what's on a lot of people's minds, and we heard a bit from each of you about the impact of CLM and how you've used the data to make change. But we did want to know if you can expand on this topic of how do you use CLM data to improve your programs, as well as using that data to impact the larger systems where you operate. I'd like to start with Grace, if you can share.
Thank you so much, Mike. And I think I started touching on this, but I'll be able to expand on it a little bit. I think right now, especially for someone like me who works within the context of key population, having client-centered services is very critical. So for us, community-led monitoring has had a lot of influences at different levels. So from what I was talking about, you look at, first of all, the influence that it has, the data that is coming out of it at facility level. And I think for us, this has really been in terms of defining the package of services for key population. In Malawi, we do have a nationally approved package of services for key population. But there's sometimes that nuances will start coming out as you start engaging with the communities. And it's important for us to keep evolving based on what feedback they're actually providing to us. So in terms of defining the service package, in terms of defining even how they want that service, those services to be provided, when the services should be provided. I'll give you another example, for instance. So in our drop-in centers, because we initially were attached to a mother facility under Ministry of Health, we would offer ART services once a week. One of the issues that came out clear was we do need the services continuously, for instance. So we started thinking around how do we start responding to that need now. So in terms of just how services are being provided, as I've said, it gives us a lot of critical feedback to define that service package. And I think when it's done very systematically in a structured manner, it also helps us to design the whole program as a whole. As we go into year after year, instead of just being stuck in one place, we start hearing how else do we get innovative. And as I said initially, communities need to be at the center of that innovation. They need to design the interventions. They need to tell us what exactly they do need us to be delivering to them. Secondly, in terms of beyond the site, beyond the facility, we now start looking at being a local partner. We want to make sure that our performance is good all the time. So it starts going now, trickling down to the organizational level performance. Because one thing that we're learning from one site would kind of spill over to lessons learned into the other sites. And we use findings from one site to just check how other sites are also doing. So changes in one site oftentimes have led to changes at program level. So that leads to even improvement of performance as a program, as a local implementer. And finally, there's the high level advocacy that I think you asked about in terms of high level systematic changes. There are so many advocacy agendas that we do have at country level, but I think advocacy is really defined by the community itself. So based on the needs that they normally bring through the community-led monitoring process, we then will prioritize based on the findings to say, these findings will be dealt with properly at facility level. These findings will be dealt better as an advocacy agenda at national level. So another example that I would bring is some of the work that we've done around PrEP in Malawi has really come out of the work and the feedback that we've gotten from our communities. So for us, it's at that different levels over time. Thank you so much. I'll hand over to another panelist.
Thank you, Grace. Just kind of direct the kind of a follow-up to Adolfo. Since Grace really discussed very well about how you've changed and adapted your package. For Adolfo, can you discuss a little bit about that impact now at that national level? I think a lot of questions are being asked of how do you make that link, that advocacy piece of CLM? A lot of focus is at the site level or at the programmatic level. Can you share any experience in Mozambique at what change have you seen at that national level with through your advocacy efforts? And you're on mute. Sorry, Adolfo.
Yes, thank you, Michael, for this question. I'm glad to share our experience. Actually, we have some great experience around that. As I was discussing with my executive director, also she was the mentor and also the one who had the vision for this intervention. In our specific context for this retention program, we are in the implementation phase. We are in the midway of this implementation phase. But as I said, in Mozambique, or specifically for Haiti, we started the CLM in 2011. And in the beginning, the main strategy was to go to the bottom, to go to the field level, to engage community and local health facilities. As we engage community and local health facilities, we start with them to implement this cycle, and they start to get excited through the results. So community were satisfied in terms of results and also health facility. After that, we have created platforms in order to present the result at higher level, provincial level, and also at national level, specifically the Ministry of Health. So we present this strategy, this model, and also the results we have from that. And as they got feedback from the health facility, the feedback was very good in terms of this strategy. Because also Ministry of Health has his own policy, which is quality improvement policy, but they were lacking some specific feedback from the community. So they asked us, they asked USAID to help them to develop specific indicators and also tools in order to incorporate on the already existing national quality improvement policy. So that was very important. Aside of that, Ministry of Health got a grant, a funding for the World Bank, and they decide to launch a call for proposal for local organizations with the aim to implement this community-led monitoring back in 600 health facilities in national level, in all health, in most of the country. So NRED have won this grant, so we start to implement this process together with the Minister of Health. So these are very important. So there are two main results that I would like to share at the end. As one of the main challenge or one of the main problems we face, or as a result of this scoring card, was 60% of health facilities have problem with water sanitation. So as a result of that, the Ministry of Health has changed and start to do a specific policy in terms of infrastructure aimed to solve this problem issue among health facilities. So this was informed through the problem, to the feedback they got from the community, to the scorecard. So because of that, Ministry of Health has come up with specific plans in order to improve the sanitation infrastructure and also provide water at health facility level. The second one that I would like to share here, I have some issue I have pointed out, is the illicit charge at health facilities. In the beginning, many of the communities have pointed out this as a big issue. When they go to the health facility, most of the health facility staff used to charge them illicit money to pay for them. But because of that, Minister of Health asked NRED to develop a specific strategy in order to prevent this illicit charge at health facility. That was in 2020, and we did that, and Minister of Health has adopted this strategy. So thank you.
Thank you, Adolfo. Those are wonderful examples. Thank you, Grace. And we can see how CLM can really tie to so many different, not just health services, but other services that will impact communities. As you mentioned, Adolfo, sanitation, and that should also help us think about who should we ally with, who are our partners, because so many different actors interface with community members. So there's so many different ways to elicit that feedback. So we really should leverage the system of actors that are engaging at the community level. Thank you so much. Shama, I have a question for you, and then we'll open to Q&A. I'm really curious to learn from you about any unexpected results or successes that you may have had, because we do know that CLM, it's not just an intervention, it's a process, and we're learning and we're constantly adapting how we work. So I'd love to learn from you and hear from you about your experience with these unexpected results or successes.
Thank you for that question, Mike. And I, please interrupt me if my video goes off again while I'm speaking. So I actually have, I think, 4 things that I'd like to share with all of you in terms of unexpected results or successes. It's really been just a year of which I think for us, the last 5-6 months have been really intensive. So we are not as far along as say, Grace or Adolfo in Mozambique and Malawi. But I think what have we seen already, and sort of has really sort of encouraged us and allowed us to sort of look at the potential of CLM in the long term. I think the one thing is that community members, and we worked with people who were not already within the HIV programs. They were not outreach workers, they were not counselors, supervisors, etc. Right? They would have typically been seen as beneficiaries or users of services. And we actually had identified them and trained them, orient them. And I think what was a success is we saw that they were really willing to engage, learn, contribute through lockdowns. They were remotely still in touch. And then as lockdowns during COVID times were lifted, we were actually able to go back to in-person meetings and in-person facility assessments and focus group discussions. I think it's really been humbling. The leadership has been amazing. And I think for us, it's very, very clear that CLM processes and mechanisms definitely add to the empowerment of the community that we want. And that's something I want to stress. I said earlier that it's part of the larger community system strengthening effort. And I think we've really seen that, right? CLM provides a platform for the community to express their leadership. And traditionally, I think few people get that opportunity at state, district, or national levels. But with CLM, we see an expanded sort of leadership emerging from the community. I think the other thing that it was really sort of encouraging for us is that across all levels, whether it was at the facility, district, state, or national levels, and especially at the district level, there was really an eagerness to see how this process could lead to improvements and change. We've had facilities following up with us to say, where are our report cards? And I said, we can't finish the analysis fast enough. So I think that is something that sort of really enthused us. I don't think we were expecting that. I think there is I think going in, we all expect that people will be resistant or that it's going to be seen as negative. But I think for us, we've been really happy that there is this much interest in actually looking at what's coming out of this process. I think something that really we saw as success is that during COVID, despite all of the challenges we've had, we actually had a very sort of really bad second wave in the country. At least ART services and a lot of the HIV services were not disrupted. The outreach services, the DIC services would, maintain themselves, and there was active engagement with the community in terms of COVID response. So I think we were actually, through the CLM process, also able to identify people and facilities that sort of went beyond their mandate. And I think this was, again, something that we had wanted to do. That was in theory. But in practice, we were actually able to say, hey, these are people that are actually doing really well, or these are facilities that are really doing well. So celebrating what is going well and sharing that learning at a district level, I think is something, again, that's come out for us. So this fostering a culture of learning and therefore modeling that this can be done this way, even in very difficult times, is an opportunity that's coming from CLM itself. And I think finally, because community champions led the efforts, right? It was their networks that they tapped into to bring people in to provide feedback. And I think what happened as a result is that they brought in people who were actually not using HIV services or were not being reached by services. In theory, again, we knew that, we're not necessarily reaching everyone, but we didn't expect to actually have people who were not using current services to actually reach out and say that we'd like to give you our perspective, right? And share that. And I think that gives us that's a signal to us that there is an opportunity to build and leverage CLM in terms of looking at the larger HIV service delivery for different categories of people, even within key population groups. Thank you, Mike, and back to you.
Thank you, Shama. And thank you so much for highlighting this key aspect of making sure that the relationships are not antagonistic. It's not just about finding out what's not working. That's not the purpose of CLM. It's also about celebrating what is working and sharing those lessons so that others can adopt it. Thank you so much for highlighting that, Shama. I think that's something that we need to stress constantly to ensure, and I've seen a lot of questions coming to all of you. But that is certainly an aspect of the core of the engagement with stakeholders, to make sure that it's not just, we're here to make you look bad. So that's something to keep in mind. So now I'd like to just open it to some questions. To all panelists, you'll see that there are more questions coming in the Q&A section. I did want to give an opportunity to Regina Bayaki, who has raised her hand. Regina, would you like to come off mute to ask your question? Perhaps it was by accident. Okay, I will then go to one of these questions that we have here. Here's an interesting question. I don't know if this is something that one of you would like to tackle, perhaps Grace. This question of engaging communities and government in providing services to populations that are criminalized. I know this is something that is certainly on the mind of a lot of our partners. Sorry, Grace.
Thank you.
Yeah, there you go.
Thank you so much for that question. In terms of engaging communities, I think communities, it's quite critical because most of us are living in contexts where the laws, the legal environment criminalizes, in this case, sex work, sometimes same-sex relationships. So it's very important in terms of just pushing advocacy. What we've done at country level, now broadly, has been to work with law enforcers, in this case, talking about like Malawi police, working with legal services to engage with them on some of these issues. But beyond that as well, to engage local leaders within the communities that we work with these issues. But what has mattered as well, the same way that we're talking about communities being at the center, it's very important for in this process as we're talking about this to ensure that communities are also leading in that in a safe manner, in a way that we can still ensure security and safety along the way. But within Malawi, what has been exciting, I think, over the past few years, we've seen a birth of key population-led organizations. For instance, we do have what we call the Diversity Forum that is led by key population. So they've been very instrumental in pushing a lot of advocacy agendas towards government, but also just voicing out some of the issues around criminalization, but also needs for services that are there. So just agreeing with the question, it's very critical that we continuously engage. The thing with advocacy is you don't win it within a day. So it needs to be a continuous process till we get where we need to get.
Great, thank you so much.
Over.
Thank you, Grace. So we do have 4 minutes left. I think we have time for one question, and I think it's come up quite a bit. And some of you, Shama, may have more recent experience with this. Others, looking back, may have some lessons to share. But what will be your advice for a new CLM venture, a new initiative that's just getting off the ground? What is something that, looking back, you would really stress? I know we've touched on different aspects of engagement, stakeholder engagement, but what is there something that you would like to share from your experience so far to a partner that's just getting started?
Do you want me to take that?
Yeah, and then we can Adolfo and Grace.
Sure. I think, like you said, Mike, I think this is a process. And for all of us who get involved in it, we're looking at how to do this really well. I think, though, one thing to remember, at least from a community experience perspective, is how do we get into sort of, once we identify certain barriers, how do we get into solving for them so that the community actually feels like something has changed? I think that, and processes can change. I saw a question on, can we use suggestion boxes? Can we use structured questionnaires? I think there's many different options that are available to get input. And I really like the fact that Grace was talking about there are multiple sources of information, right? So I think it's important to understand where information is coming into the system at a district or a national level, and start possibly from there. As long as you're bringing the community to the table, they're part of the planning, the thinking through, and the problem solving and ongoing action. And this can be done systematically. I think it being open to the process itself could evolve, right? And there is not a sort of a perfect way to do this. We will all find something that works, but I think really being able to get into action and for the community to feel that they were involved and could change something, that shift will allow the system to sort of incorporate that and move forward more quickly. And at least in the Indian context, decentralizing that and allowing wider community engagement in this process is, I think, really something that I would say is really important. Thank you.
Thank you, Shama. Adolfo, would you like to take on that question too?
Yes, few words from my side. What I've seen is that communities don't like to have program to do the things for them in this context, but I have seen and it seems that they feel more than happy to be part of the problem solving. So it's very important to involve communities throughout all this process because the community feels the ownership of that. And it's very, very happy. They become very happy when they go to the health facility and they can see that that was one of the problems, for example, that they pointed out in the past. And they sit down, they brought out some solution or proposing some solution, and now they can see their improvement. So they see and they feel that their voice make difference, their voice matter. So when they see that, it's more easy to have them on board of whatever specific issue we need to solve or to improve. So community should not just we should not do things for community only, but they should be part of the solution. They should feel that they are part, and they should feel that we value their ideas, their comments, the experience, or the way they see the thing. So this is very important. That's one of the main things that I would like to share.
Thank you, Adolfo. And I apologize, we are at time. Grace, Shama, Adolfo, thank you so much. Thank you, Sina, for being our note taker, Latham, Alan, for being our technical moderator. Thank you all for attending. We will share the presentations that were shared, but thank you once again. And please be in touch with everyone that was on this panel. They are wonderful experts on CLM, and we're here to help you figure out and answer any questions that you may have. Once again, thank you again. And have a wonderful, wonderful day and evening. Thank you, Shama, Grace, and Adolfo. Thank you so much.
You're welcome. Thank you for the opportunity.